Welcome Tobias Kennedy, President, Montage Insurance Solutions and CEO, Sim Policy Insurance Solutions, presenting California Single-Payer Healthcare System. As the state explores this legislation, we'll explore what this means for you and your company.
Hello, hello. All right. Pyra. Woo, that's right. Main stage. How about that? This stage is far too big for my purposes. I won't be going over there at all. I was wondering if they were going to put me in, I don't know, a broom closet or some like annex parking lot somewhere. Or where was I going to go to give this talk, right? I was very confused when they put me on the main stage. So thank you guys for coming out, and thank you for everyone that's streaming as well. My talk today is something that, I really just kind of had on my heart. So I have been fortunate enough to speak for the organization and several other organizations on everything from, building employee benefits portfolios to HRIS systems and a lot of different topics. And when I was asked to talk today, I wanted to do this talk. So let me give a little bit of background and introduction. My name is Tobias Kennedy. I am the president of Montage Insurance Solutions, the CEO of Sim Policy, which is another insurance brokerage firm, and I have spent my career in the insurance space. I've been in the insurance space for a long time. I did my degrees in political science, and when I was coming up in the insurance world, the Affordable Care Act, which passed on March 23rd of 2010, was a big deal. I did a lot of speaking on that. Also, tangentially, because of what I do for a living, I do a lot of open enrollment meetings for employers and clients. And I tend to find that my talks go like the movie theaters where they fill up from the back forward and nobody wants to sit up front. So I understand, but thank you for moving people along. Okay, so long story short, I've been in insurance for quite some time. I have a background in sort of the political and legislative slant to some of these things. And I was fascinated by the single payer healthcare proposal making its way through the California legislature. And I got into conversations with people and I chatted with people, and I was very, very moved by the fact that most people had kind of a sentence or two soundbite that helped them wrap their heads around what a single payer healthcare system even is, or what the California thing was. But really and truly, how deep do they go, right? And one comment I've heard throughout this conference is how many people are just excited to be back, right? We're together, we're having, time, we're sort of eyeball to eyeball. And as a result, last night, there was an event after the day's content, and someone kind of asked me like, why are you diving into this? And I said, well, I almost think that it reminds me a little bit of sort of like a Brexit situation where this is a major legislative conversation, and a lot of the folks kind of pulling the lever maybe don't have a full context to it. So, I joke that I'll do like a John Oliver style dive into, what this sort of is. So that's a long introduction. Part of it was because the mic went out, but anywho, let's get into the actual content. And I will look at my clock there. Okay, great. So, today's agenda. Okay, so first and foremost, I want to give everyone the lay of the land, right? Like, hey, we're talking about fundamentally revolutionizing the way that people get health insurance. This is not the ACA 2.0. This is not a redo of something minor. This is a transformational change on how we do health insurance. This is a really big deal. And so if you're going to engage this major shift, we should be aware of where the pieces are on the board today, right? What are we shifting away from, right? I will then get into what is a single payer system, right? So I've had this conversation with people and folks I've talked to are all over the map. I've never even heard the term I have a fully formed opinion on the matter, and that's great. This conversation will apply to everybody. What did California's recent proposal look like, right? AB 1400, let's dive into the actual proposal that was on the books. What were we looking at? What are some alternatives? Okay, so if a single payer healthcare system winds up being too big of a lift, what are other legislative possibilities that may be explored, that may come down the pike? And as you guys are giving me a little bit of your time, let me give you a little bit of my opinion on some things that may come down the pike at some point. And then lastly, what are some important considerations for employers as they look forward? Okay, great. How are people getting their health insurance today in California? And a little look back, right? So with this graph here, what I want to point out, my main point here, I want to steer everybody to the sort of gold line, right? In this, I don't have a pointer, but the gold bar there, that is the uninsured, right? And this graph goes all the way back to 1987 when I was just a budding young insurance executive in the field. I was giving this talk and I was like, oh my God, like I'm going to have to face the fact that some people listening weren't even born in 1987. This is a new reality for me. But anywho, my point is 1987. How many people are uninsured in the state of California? About 17.5%. All right. So about 17.5% of people don't have health insurance in 1987. And that gold bar stays fairly flat for a long time. And then it falls off a cliff, right? Somewhere around 2012-ish, it falls off a cliff, right? That's my main point with this graph here. Okay. And now let's dive a little deeper into when it falls off a cliff, right? So 17.5% of people don't have insurance in 1987. This graph, if you look at the kind of, I don't know, pea green, sort of a green, it's about 16.5%. So that consistent line goes all the way through and it takes us to 2013. And in 2013, in the state of California, 16.5% of people don't have health insurance. And then it drops, right? So we see it go to 11.5, 8.5. This really precipitous drop in the uninsured rate in the state of California. And what I want to kind of point out is this really interesting sort of almost inverse graph, this kind of mirrored relationship between the uninsured rate sort of plunging down in that 2013, 2014 and beyond timeframe, and how the Medi-Cal insurance insureds sort of went up at a very, again, mirrored kind of a rate, right? So that is what was going on in the state of California at that kind of a time. And what I want to do is talk about a little bit why, right? If we went from 1987 all the way to now, we had a similar uninsured rate. Why did these things happen? Long story short, the Affordable Care Act, right? Again, it passed in 2010. And one of the main things that it did was to expand Medicaid, which in our state we call Medi-Cal. So a lot of people moved on to coverage from Medi-Cal, and that was a big reason for sort of the shift there, right? And that's what that graph kind of tells you and what's kind of going on with that graph there. Okay, so we have the Affordable Care Act, and that sort of makes a major drop in our rate of uninsureds, and that was 2013. This graph here, a really interesting conversation from UCLA, takes us all the way to current. And when we look at the current rate of uninsureds in the state of California, we're at about 6%. 94% or so have health insurance today. About 6% are uninsured. So that's the lay of the land as far as who has health insurance in the state of California. Now, one big conversation to have around this is who are the 6% that are uninsured, right? So let's dive into that group. Okay. Now, 54% of our uninsureds are made up from people that are eligible for Medi-Cal. So potentially an education problem there, right? Maybe some folks don't know what Medi-Cal is, right? It's our version of Medicaid. It provides low cost or no cost health insurance to folks whose sort of income is lower income. So it's a nice program. Or you've got folks that are eligible for their employer and they're just waiving their employer plan, right? So for one reason or another, they're waiving their employer plan, or they're eligible for the marketplace with subsidies. Small sliver at the top of people that are eligible for marketplace plans, but not eligible for subsidies, right? And that's typically because they earn too much, right? They have too high of an income, right? So that would be sort of that group of people. And I'm going to drill down a little bit on why it's important to know what the marketplace subsidies are and sort of, hey, if you're eligible for the marketplace with the subsidies, what are those, right? So in the Affordable Care Act, especially in the state of in California, you can get Covered California. They have two types of subsidies. The first type of subsidy is a premium subsidy. So for folks that maybe can't afford the health insurance on a monthly basis, you're trying to get on these plans, they cost you more than you can kind of put out for premiums. And that's for folks that make all the way up to 400% of the federal poverty limit. So You've got this premium subsidy for a lot of folks. What you also have are cost sharing subsidies. Okay. A second subsidy that goes into the Affordable Care Act manages things like copays, deductibles, out-of-pocket maximums, right? So for folks earning, and that gets a little bit more of a sliding scale, but let's say up to 150% of the federal poverty limit, for example, they take these plans and they really reduce what your copays and your deductibles are. What I want to do is drill down really quickly as a sidebar on what that means, right? So there's a term in health insurance underwriting called actuarial value. It's not a really sexy term, but what it means is if I take you guys through this plan design, your mileage may vary, right? Individual people may vary, but if I took 100,000 people or 1 million people through this plan design, how much of what went to the providers would be paid by members, deductibles, co-insurance, co-pays, et cetera, and how much would be paid by the insurance company, right? That's what an actuarial value is. So when they look at the robustness of a plan, they're looking to say, how much am I levying upon you, the member, and how much is the insurance carrier going to pay if you're on this plan design when you get your surgery, have your baby, break your ankle, et cetera, right? The lowest level plan you can sell by law is a 60% actuarial value, right? So we created these metal tiers where bronze has a 60%, silver has a 70%, gold has an 80%, and platinum has a 90% actuarial value. With the cost sharing subsidies, they do so much work on these copays and deductibles that they take what would be a 70% actuarial value plan all the way up to a 94% actuarial value plan, right? So really low member responsibilities. And this is going to tie into something we'll talk about later, right? So it's worthwhile to talk a little bit about actuarial value for a quick second here. Okay, so I talked about how 94% of people in the state of California have health insurance as it stands today. There's about 6% that are uninsured, and I lumped a bunch of groups together to get to 54%. But quite clearly, the largest group on this uninsured graph are undocumented folks, right? Mostly between the ages of 26 and 50, and they're not allowed to participate in Medi-Cal as it stands today. So when we're looking at the state of health insurance in California, we've got a lot of people on some version of coverage or another, whether that's their employer plan, an individual plan, maybe a military plan, et cetera. We've got this 6% of people that are uncovered, and here are our 6% of people that are uncovered. Now, interestingly, Governor Newsom, who has released his 2022-2023 budget, included an expansion of Medi-Cal to folks regardless of immigration status. So there's an attempt to work towards what would be on paper, at least some version of universal coverage, right? That's something that is coming down the pike that folks are working on as it stands today, right? And I say all of this to say what we're doing is looking at, again, a major piece of legislation, and it's attempting to completely change today's system. So I want to be clear on where are we today. Now, that being said, AB 1400 was a single payer, quote unquote, style health insurance program. So what is a single payer health insurance program in and of itself, right? What I'll start with is what it's not, right? So some people kind of mix up terms a little bit where they say universal coverage and they say single payer in the same breath. And I want to kind of parse those two out. Universal coverage really just means that en masse, your people have access to and are generally covered by health insurance, right? Don't really care how it's done, whether it's, again, an employer plan, an individual plan, whatever, but everyone has access to health insurance, right? And you can contrast that against the days pre-Affordable Care Act, where people had to be underwritten, people were declined, maybe their employer didn't offer health insurance, right? So there was a world where we did not have universal access to coverage. That's universal coverage, right? Single payer gets a lot more specific about the manner in which everybody is covered, right? In a single payer system, the government becomes the one and only payer of claims. And I'll use a few very, very highly designed graphs to go through this, right? So big splurge on the budget here. These are my patients, right? So what you have is patients, okay? You have people that have a medical need, right? So let's say they have an appendix that needs to be taken out, right? I have a problem. I have an appendix that needs to be taken out. Great. What we also have are providers. Good news. We have people that write prescriptions. We have people that do MRIs. We have people that perform appendectomies. Good news, right? There's human beings out there that are capable of doing what you need. So you have this medical need for your appendix to be taken out. We have folks that take appendixes out. Now, unfortunately, the people that take appendixes out have to do it in a building that should probably have lights on. So someone needs to pay the electricity bill, right? Out front, there's a nice lawn that needs to be watered. Someone needs to pay the water bill. We also have the doctor who has a salary. We have all these reasons why our providers need an exchange of finances. So you have human beings with a medical need. You have providers of care that need finances. And that is one fundamental reality. In today's world, we have insurance companies that the patients peel off and join. And the patients, through some version of their copays, admittedly, right? But when we talked about actuarial value a moment ago, typically speaking, they're paying their insurance company with premiums, and their insurance company is paying the lion's share of the claims. And under this sort of a setup or a system, that is how most people are getting to access their providers, and their providers are being paid for the actions that they take on a health insurance basis. And this is a sort of iterative thing where the patients all disperse amongst Anthem and Cigna and Blue Shield and all these different places. And providers of care today are getting this kind of fragmented income coming from the various insurance companies, the various copays, the various plans, the various things out there, right? That is today's system. Should be reviewed for most of us. Now, a single payer health insurance system says, hey guys, scrap the insurance carriers. Let's get rid of all those guys. Scrap even things like premiums, and for the most part, scrap copays. Let's replace those premiums with taxes, funnel those to the government, and the government will pay the claims to the providers and do that times everybody that's on a different plan design, right? So everybody pay into the government, and the government will be the one single payer of claims to providers, right? So whether that's someone that needed an MRI, a trip to the pharmacist, surgery, whatever the case is, fundamentally, that is what single payer healthcare is. Now, some folks might say, cool, I'm looking at this on paper. This is an interesting theory. Are there examples of this worldwide? And yes, of course there are, right? There are countries who have their citizens' access to healthcare set up on this sort of single payer style. And so we can look to those and we can say, all right, then now this has gone beyond paper and pencil theory. This is an actual way that people receive healthcare. What do the proponents argue, right? What do single payer advocates say, right? And of course, the first thing is, look, once you have one entity doing all of your negotiation with providers, they have the ability to put some downward pressure on what's an acceptable rate for an office visit, right? What's an acceptable rate for a this or that prescription, right? And potentially more importantly, you circle back to the slide before, there was a lot of little red arrows that I needed to draw in my graphics because the providers are receiving care from lots of different insurers, right? There's thousands of hospitals and doctors and different billing systems and different insurers. And it's a little bit fragmented, and that therefore adds to the administrative costs. So the idea is perhaps if we had one channel that providers were paid through, then that would reduce some administrative costs and potentially reduce some of the costs of healthcare in this country, right? That would be what the proponents of the healthcare single payer system would say. And I think in some of my conversations with folks, a lot of people look to and think of Canada, right? Canada is a place where all legal residents and everyone that lives there has to get there in their province or their territory, the coverage from the one government insurance plan, right? Now, some things live outside of, and folks buy these kind of supplemental plans. So historically speaking, things like home health care maybe lived outside of, drugs lived outside of the kind of provincial plan, but that's sort of the main structure where they don't necessarily employ or own most doctors. It's or the hospitals. It's kind of a Medicare adjacent system where it's, hey, look, we've got private providers of care that are publicly financed, and that's how they're paid, right? So that's kind of one key example. And when you look at things that live outside of the single payer system, for example, in France, right, dental and eye care tend to be covered with their citizens by supplemental policies. So you have this dialogue about what's in the government plan and what might members need that lives outside of, right? What's the community's responsibility? And this gets to a really fundamental part of this conversation. Because when you think about it, you wonder like, okay, what's something that we're going to include for all citizens and what's maybe something we've determined to be extra, right? So think about, for example, if they came up with this surgery and the surgery costs $50,000, but if you're a 65-year-old man with kind of a creaky knee, when you get up, you don't have the pain anymore. Like, okay, great. Some people might want to buy that procedure. It's a little expensive. Do we as a community want that included in the thing that we all pay for? Or do we want to carve that out and have that something that you buy separately, right? Or maybe a better example would be a pregnant female who wants to know the gender of the baby at X weeks, but it's not really medically necessary until this other date. So if you want to know that information, you go pay for that yourself, right? When you have a community-based healthcare system, there needs to be conversations about, well, what are we all willing to throw into the pot and let people access? And what feels like something that people should buy on their own, right? You get into these types of conversations. And because you have growing and aging populations, you have technological progress, right? I gave that hypothetical example earlier of the 65-year-old. And even if you get rid of all of the waste, right, all of the administrative costs of the multiple different players involved, you still have these fundamental upward pressures on claims, right? And so you end up having to have this conversation where, as a community, what are we including? What are we excluding, right? Those are some of the fundamental challenges, right? And it's a pretty persistent fact of life that in a lot of countries with single payer, you end up saying, okay, the payers try to squeeze, right? We're using taxpayer money. We can't have this ballooning budget. And then the providers of care protest, right? Hey, well, hold on now. I need a certain amount of money to run my operation over here. And it goes in that sort of a cycle, right? So that ends up being something that gives the detractors their on-ramp, right? Because when you talk about cost containment, you've got these mechanisms built in, right? So in France, for example, their parliament has legislated an annual spending target. We can spend X on healthcare, okay? And in Canada, Great Britain, the budget itself is at ceiling, right? But over and over, you've got these public constraints on what can be spent on healthcare. So if only a certain amount of cost can be incurred, then only a certain amount of care can be administered, and you wind up having detractors equate caps with rationing, right? And so you get this system where that's what the detractors would say, right? And you look at a Canadian analysis of 2,060 referrals. It's a really big kind of meta-analysis where the median wait time between referral from general practitioner and receipt of treatment is 25.6 weeks. That's up from 22.6 weeks the year before and up 175% from when they started this in 1993, where it was just 9 weeks. So this public pressure on how much can we spend has to manifest itself in some place or another. And that would probably be the biggest thing that detractors would point to, right? We've talked about calls of, wait times to rationing, but, it's one of those things to where even in Sweden, New Zealand, where they sort of, quote, do it right, they have legislated acceptable waiting times, right? Where in Sweden, it's 60 days. In New Zealand, it's 6 months. And I think to some Americans, that feels like a long time to wait between referral and receipt of care, which is a reality in these systems that needs to be talked about as we talk about the idea that, well, hold on, we live in a world where some people bump into financial troubles because they got sick, or some people are bankrupt because of something they couldn't help, right? We really need to look at this healthcare system in general, and where are we sort of putting our pros and cons, right? And the US has done this for a long time, right? Our conversation about looking at healthcare in this country is not new, right? There was a 1943 bill that was subsequently endorsed 1945 by Harry Truman that envisioned a national plan. Even the architects of Medicare themselves thought, all right, we're going to start with this older population, but that's just going to be the cornerstone of a national plan that's going to be funded by a payroll tax. Maybe we'll fold children in next. And at some point, we'll have care for everybody, right? Liberal senators like Uncle Teddy, right, in the 1970s, really looking at this sort of a thing, saying, hey, I've got support for this. It's not new to have support for legislative conversations around the way we get healthcare, even Medicare expansions along the way, right? Prescription drugs, et cetera. And the 2010 Affordable Care Act, right? That is a major sweeping piece of legislation that really touched everything from expanding Medicare, as we talked about earlier, to a whole conversation about a public option. And what a public option is not necessarily replacing healthcare with a single payer like we've been talking about, but let's maybe introduce another competitor to the market, right? So in the same way that FedEx delivers envelopes and so does the USPS, right? The US Postal Service, there's worlds where governments compete directly with private enterprise, right? And maybe at least in this case, we'd have more oversight, et cetera, et cetera. And even with Democratic majorities and a Democratic president, the public option ended up getting scrapped, right? So there's the conversation that I'm having here is that it's a big political lift, and it's not something new, and it's something that we've looked at for a long time, but it takes a lot of work, right? And that forays me into state by state. So some of this conversation we've just been having has been on a federal level. A lot of people maybe don't know Vermont passed a single payer system in 2011. Vermont is a wonderful state to look at a case study on single payer healthcare because for a couple of reasons. Number one, Vermont is one of the more, politically palatable places for something like this, but it passed in 2011. And as the story goes, when they're working out the finance details, you had Governor Shumlin, who at the time really put this forward as his major legislative accomplishment, saying, this is the greatest disappointment of my political life so far. We have to scrap it. So in 2014, before it even got off the ground, Vermont's healthcare single payer system never got executed, right? And what a former staffer was quoted as saying in an article was that the pressure was on us to get the payroll taxes under double digits, which we couldn't figure out how to do without making the income tax too high. In other words, they had a lot of political will to pass this, indeed did pass this. But a couple years later, when it came time to figuring out how to pay for something so big as a single payer healthcare system, they literally couldn't do it. And again, this shows just how hard it can be because Vermont itself is a state with, by the way, only one major insurer. So the disruption is very minimal. It's Blue Cross Blue Shield of Vermont. They do a great job. It's a super homogenous state. They literally share a border with Canada, so they actually physically see a single payer system. Their claims are pretty low, right? So the dollars, the reserves that you're talking about are not as expensive as maybe some other states that have more claims than someone like a Vermont might have. So you look at how ideal a state like Vermont is for this, and Vermont not being able to get this done is something that I think is a pretty big deal. And again, what they ended up saying was, man, everyone wants this passed, but the taxes that we would need to levy upon Vermonters just to get them coverage that's comparable to what they have today is shockingly high. And larger employers said, hey, look, we've got guys from Massachusetts, New Hampshire, New York, et cetera. If you make me get rid of my employer health insurance and I've got someone coming over from Massachusetts, does that person get to get the Vermont health insurance, or do I just become less attractive because I'm competing against other employers for talent and you won't let me offer a health insurance plan? That's trouble. And then the flip side is some of the smaller employers that said, hey, I don't offer health insurance. So when you're telling me I've got this new payroll tax that's coming down the pike, but don't worry about it because you get to stop paying for health insurance, that doesn't help me. That doesn't help my budget because I'm not currently paying for health insurance. And there's this great quote from a fellow that was on the advisory council when Vermont was trying to do this. And he says, we never figured out the creamy stands, these kind of soft serve ice cream places. The notion that we would put all these beloved businesses run by our cousins and neighbors out of business because of this payroll tax that we need to charge to fund this single payer system, it was tough. It was tough, right? And again, I say all of this to say because in Vermont, they were an ideal candidate, and it's just such a big political lift. And we have examples from history where we can look at folks trying this to see whether or not it can get off the ground. So with that, let me get into CAHR, right? AB 1400, it sought to abolish health insurance entirely in the state of California. No health insurance, no health insurers, no other option for Californians. You go on CAHR. No copays, no deductibles, no premiums, right? Designed with equity in mind, but something sort of needs to fund this, right? And when you look at California's current budget, its whole annual budget today is $262 billion. That's what we run the state off of today. The budget for CAHR was another $400 billion. So I set up with Vermont and how they tried this and they realized, crikey, this is a lot more than we thought we were getting into. This is another $400 billion. And Californians, by the way, already pay some of the highest tax rates in the country. So you're looking to say, we run the whole state off 262. I need another $400 billion. And I'm underscoring what a big political lift this is, even when ideologically we think to ourselves, hey, I don't like the idea that we've got some uninsureds. I don't like the idea that we've got some underinsureds. Fine. But I think that there's some evolutionary aspects to healthcare systems. And when you kind of find yourself where you are, there might be other alternatives to look into. So let's dive into what AB 1400 had, right? So first and foremost, the bill passed through the kind of legislative process without really having a financing attached to it. The financing was something called ACA 11, the Assembly Constitutional Amendment, and that's how they were going to finance this CAHR bill. So you've got the CAHR bill and you've got the financing aspect. And the financing aspect was as follows. Number one, 2.3% tax on California companies' gross receipts, not profits, gross receipts. Employer payroll tax of 1.25%, employee tax of 1% if you're earning more than 50K, personal income tax, a couple of other things, but probably most importantly, presumed that California would get waivers that would allow us to use all the federal funds for things like Medi-Cal, Medicare, et cetera, to go towards CAHR. Now, these waivers come at White House approval. And I don't know how many of us watch the news every day, but there's actually some changes in Washington from time to time, and some presidents that are more favorable with California and some presidents that are less favorable with California. In fact, might have some fun sticking it to California, right? So now you've got a major part of your budget that's totally up to the White House. All right, that seems a little dangerous. So what we're going to do is we're going to pass the ability for us to generate extra funding if need be, if White House doesn't approve sort of, giving us those waivers. Well, that might happen, right? So quick civics review in California, we have something called Prop 98. 40% of our general ledger has to go towards education. We also have something called the GAN limit, which prevents the legislator from raising taxes or raising spending too much without voter approval. Great. This legislation required a constitutional amendment so that they can raise additional funds without voter approval anytime they run out of money. That's a little scary when a major part of your funding is coming from the White House's whims, right? So long story short, it's one of those things to where it gets a little bit bigger and away from us kind of the more we look at it, right? So this was the California legislators' sixth attempt since 2003 to pass a single payer bill. This didn't move that far along, but it's an election year. So they scrapped it at literally the 11th hour, the last possible point at making people go on record, because I think they knew, hey, I want to know, where's my California legislator coming down on this? Where's he going to vote on this, right? So he or she. So you look at these sort of things, go, okay, they've scrapped it for now, but it's one of those things that will constantly be promised to be back in the conversation. And what I think is worth talking about is, hey, look, first and foremost, I know it's not the universal care we all kind of thought and promised, but Gavin Newsom's recent budget, like we just said, will extend Medi-Cal to all individuals regardless of immigration status. So California might be one of the first states in the union to have darn near universal coverage anyways, without an extra $400 billion coming down the pike. So something to look at and something to think about. And so what I wanted to leave everybody with is a conversation about some potential alternatives, right? Look, thank you for explaining single payer. Thank you for talking about some of the price tag. Thank you for talking about some of the difficulties in places like Vermont that have tried it and failed, right? Places that were a good candidate for it. What might we be able to do? Because again, we live in a world where it's not a perfect insurance system. So one thing we talked about earlier was a public option, right? That is where you have the government either owning an insurance plan that competes against the Anthems and the Cignas of the world, or what's more common, kind of instituting rules to administer one of those plans, right? Because what's difficult for a state government to do is start an insurance company because they don't have the funds and reserves, right? You can't build up reserves overnight. So in theory, the public option is something that kind of exists where it's most likely to be something that where states put on extra requirements in order to participate. And it has happened, right? The state of Washington passed a public option in 2020. In Nevada, it's coming in 2025. In Colorado, it's coming this fall for those guys, right? So they're going to have a plan competing alongside of the rest of their insurers that will help them to sort of keep an eye on, costs, right? So whether or not this expands enrollment, jury's still out, right? And Sabrina Corlette's a great luminary in the field. But so long story short, what you end up saying with these public options is, look, let's get some government run insight into healthcare, and let's put that beside our other kind of competitive healthcares, right? So maybe California does a public option one day, and maybe that's another one of the ways that we have legislative levers pulled. The last couple things I want to talk about were maybe there's ways, hey, look, if we talk about the uninsured and the underinsured, maybe there's ways to look at HRA style cost subsidies, right? So we talked about in the individual marketplace, there's those cost sharing subsidies that folks get that change the actuarial value of your plan. Maybe what we come up with is a legislative acceptable actuarial value. And so everyone's got their own health insurance plan, and you have some vehicle to submit your income to the government, your underlying insurance plan to the government, and then they help you with co-pays, deductibles along the way to make sure that your costs don't get too out of hand. That's a possibility. And what's interesting is that already leans on some Affordable Care Act realities where it's like, look, we have minimum plans. You can't sell below a 60% plan. So don't worry about employers kind of blowing up their health insurance and just leaning on government subsidies, right? Also, again, if you design it to where it's income-based, employers have other pressures and realities from a wage standpoint to attract and retain kind of top talent. So it allows them to sort of say, hey, look, before I just blow up my plan design, a lot of people on the higher side of my wage scale wouldn't be eligible for these subsidies. So what it does is it picks up some of the workers that work for your plan to where what you pay them, what you offer from insurance, maybe they need a little help with co-pays and deductibles that would be substantially less expensive than a full-blown single payer system, right? Because you're leaving in the employer dollars, you're leaving in a lot of the other players along the way, or looking at things like super users, right? So another part of the Affordable Care Act was, hey, Mr. and Mrs. Insurance Company, you have to hit medical loss ratios, right? It's 80% in small group, 85% in large group. In other words, when you price for a plan, you have to spend 85 cents of every dollar you get directly on claims. The remaining 15% can go towards things like, making your payroll, paying your brokers, your reserves, your advertising, all those sorts of things. So you already have carriers carefully looking at what might be my claims exposure and what should I charge in premium. If you found some way to legislate triggers for a super user, and they could give those bills to the government, then the carriers would be on the hook for a different amount, right? So for example, 50% of claims dollars are taken up by less than 5% of enrollees. The average American cost in healthcare per year is $264. The top 5% spend $50,000. The top 1% spend over $100,000 in claims. So there's a very small sliver of folks that are using a lot of the claims dollars. And if you're able to legislate some of those triggers, tell the insurance company, look, you still have your medical loss ratios, so you cannot earn more than X amount of profit. But if you have these sorts of claims, they trigger super users, we'll pay those. They might be able to offer the same insurance for literally half the price tomorrow, right? If you cut some of these guys off their balance sheet. So in other words, what I'm saying is, I think there's additional legislative levers we can look at where we say, we exist in a world with private health insurance and government intervention, and we're trying to find ways to marry these things up so that we get the most effective system today so that people aren't going bankrupt because of medical claims or they're not being denied coverage and those sorts of things, right? So lastly, as we look to the future, the couple of parting thoughts: how might this change insurance in California? When you do your SWOT analysis as an HR professional and you look at where does health insurance fall on your recruitment retention sheet, right? Hey, it's really important to us. Well, are you considering that with the stroke of a pen that might go away and it might uniform, right? Are there other things you can look at to help you be an employer of choice, right? Also, multi-state employers. We talked earlier with Vermont, some of their people that commute, probably less likely with the size of California that you drive in, work for the day and drive home. But there's probably plenty of employees, especially post-COVID, where, hey, our California-based staff do this, but our plant is in Texas, or our accounting is remote. Those guys are scattered across multiple states. So if you as an employer do away with your healthcare plan, do you offer just an outside of California? Kind of what's your conversation with your broker, your consultant, et cetera? So making sure that people are kind of thinking about all of these potential realities within the health insurance world that may or may not shift. Now, as I get to the end of my presentation, I just want to mention, thank you guys for sort of sitting in here in the pocket with me. And if you have interest in stuff like this, there is a whole governmental affairs part of PIRA. I have Dana with me here to talk about what makes that special and why you might want to engage yourself in that. I think it's a really great conversation. I'm so thankful that you are willing to share a stage with me, Dana.
How about a hand for Toby? Isn't that great? I actually grew up a little bit with the ACA. My son's father was originally was a board of directors at CAHR, and he helped draft it way back when, post-Hillary, prior to 2010. It changed. My son is an attorney at a health services law firm. He is a Medi-Cal, Medicaid. I haven't heard this explained as well as Tobias did. He did an excellent job. So why would you care about the legislation? Because most of us in HR are incredibly overworked, okay? And we can't really think down the pike of what's going to happen in Sacramento or Washington, because we're so busy trying to figure out which new laws were implemented now. And when that happens, what happens is we get laws that are a mushy mess. They don't apply to our employer or the size of our employee group, or they may not meet our recruitment and retention needs, or they're just so bundled up between having municipalities, one rule there, and you know different pay levels in different counties or different cities, that it's untenable, and let alone talk about leaves. So we've had, and I've been really honored to be a member of the California Legislative Affairs. It has now morphed into the governmental advocacy team. I worked with Marilyn way back when Marilyn Monahan was the chair of Legislative Affairs, and it went to Sarah Prince of United Agency. She was the chair, and I got wonderful coaching on what to do. And we've watched. Our job is to educate you, to advise your companies and your people and your options, and to go to Sacramento and advocate on behalf of you to make sure that we have laws, rules, and regulations that are sensible, okay? And sometimes, even when the heart's in the right place, and I'm Canadian, so like, Toby and I had a conversation about this. Like, I don't think there's anything wrong with having a public educational system or public health care, but we got to pay for it, and people want their options, okay? So that's where you and I come in. We need to hear from you. We're right down here by CAHR and SHRM, I should say, and PIRA. So we're right here. We'd like you to come over and vote at our booth for two bills that we are currently floating in Sacramento. I think we have a doggone good chance of passing those bills. How you can get involved? We have 17 different chapters. We have an opportunity for a government advocacy chair in each one of those chapters. Most of them will get the new legislation and they will present it to your meetings. This is what the new legislation is. We have an advisory committee that I am honored to be a part of. Most of them are either insurance or HR leaders or employment attorneys. And we look at rules, regulations, laws, and we advise on them. Now, what's happened that's different? In the last couple of years, we've had legislators going to our colleagues at CAHR or going to us, your representatives, and saying, what do you think about this law, or to looking at this way? That never happened before. We spent all of our time getting recognized, and now we're starting to be recognized. So how are we starting to be recognized? We have a coffee hour where we have legislators come about eight to 10 times a year to speak to us for 1 hour. We're starting a new Adopt a Legislator program where you can go, if you join us, you can go to and visit the legislature in your legislator, senator, assembly in your district and talk about these major bills that we don't know enough about. We can work them out. It's a sensible thing. We can have the cake and eat it too, but there's a lot of complexity and we got to work through it and develop plans. And then ultimately we're not positive to have a town hall this year. It's an election year. We're hoping to have our legislators and the employment and the labor committees come down and talk to us. That's to be determined, more to come. And with that, I'm going to exit. Visit us at our booth and come and vote and get the nifty little buttons. Okay? Bye.